Good afternoon, everyone. This is Megan Fournier with the Home Care Alliance, Massachusetts. Thank you for calling in for this discussion. I know everything is COVID-19 right now, but we really are glad that you're able to call in. And Barbara Citarello was very willing to do this for us. She actually was the one that volunteered to do this. So just a couple of logistics before we begin. First thing is everyone's going to stay in mute only. We have over 100 people planning on calling into this, so it would be too chaotic if we do that. You can type in questions at any point in time during this call, and we'll kind of do it as a discussion basis where, I can interrupt Barbara during the few slides that she has, which are more of just a resource. This is being recorded, so if you need to call out because you have another meeting to go to or anything of that sort, we will provide it to all of our members afterwards. And lastly, there is a one-page handout that has been attached to this control panel, in the handouts tab that you can download. I will also email it out afterwards when everything's been recorded. So with that, again, if you have questions, type it into the questions box. We'll get to as many as we can. If we run out of time, we will compile all the questions, and you can email me afterwards as well, and then we'll send it over to Barbara to kind of do a FAQ document that we can send out afterwards. So Barbara, take it away.
Thanks, Megan, and thanks everybody for joining us today. This came about because Pat Kelleher and I had been emailing back and forth, and we were a little concerned about where home care was and the health hospice and non-skilled home care being at the bottom rung of the ladder in regard to personal protective equipment, quite honestly. And so we decided to put this together. So I'm going to move my slides here. So I wanted to just start with a little bit of humor. It's really important for us to keep laughing. And I know you're saying, how is that possible? We need to do it to keep our sanity. So those of you that know me know I am an animal person. And I just thought this was kind of funny that cats invented social distancing. By now, we're all getting pretty darn tired of social distancing. And if the government doesn't do something soon, I think they might have a rebellion on their hands. But my goal today is really to do a situational awareness presentation, just to let you know what's going on, where we are, what's normal, what's not normal in this situation. So I just want to let you know that everything that is occurring right now is everything that has been predicted all the way back to 2006, that if we were ever hit with a pandemic, this is exactly what we would see. We would see social distancing, we would see personal protective equipment shortages, we would see ventilator shortages. And even though there's a lot of media hype, we're not seeing anything that, for those of us that have worked in this arena of disaster preparedness and have worked on many federal documents, we're not seeing anything unusual here. I just want you to know that. It's not comfortable for us because it brings us to practice at a different level. But for any of you who attended the webcast that I did on the 13th of March, on March 12th, in a non-confidential government meeting that I was attending, it was announced at that time, which was probably about 10 o'clock in the morning, is that the federal government expected us to be without PPE within 2 to 3 weeks. And that was a public statement, and it went out to all different types of partners in regard to the healthcare preparedness planning program. So this is not a surprise. As you know, we experienced this after H1N1. So we're in exactly the same place. They're pulling out the same exact documents, reuse documents, quite honestly, on N95 respirator masks. Their template for that is a position paper that I was part author on back in 2010 on reuse of N95s. So we're going back to our archives to pull out information and try and put it together. Now, you already know when you're looking at the slide that symptoms of who is at risk, but I want to point you out to the last 3 bullets, because this is what is showing from our statistics that men over the age of 35, and as they age, if we give them 45, 55, 65, as they get, and we look at the older groups, they seem to be more susceptible than women. We know that smokers are having a very difficult time and are at significant risk. And of course, we know about the elderly and multiple comorbidities. There's so much data that comes out that we have yet to really analyze the majority of it. But this does tell us that right now men are leading in being ill. And we would, of course, expect anybody who had been a smoker or is currently a smoker, or anybody who's vaping, anything that's going to have a long-term effect, a chronic effect on the lungs, of course, will be more at risk. So that's some of the data that's coming out. Today, President Trump issued statements to all the hospitals across the country. He wants to begin collecting data. They want to know how many tests they're doing. They want to know their findings. They want to know their age. They're looking to pull all the data together, which is one piece that has been missing. What I hear over and over as I work with many different states across the country is that at the local level, we're pushing information up, but we're not getting anything back down. So I just wanted to give you that little bit of update. We have always had a pandemic plan after 9/11, and our role as a home care and hospice has always been to be part of all three of these components. You know that I serve as a subject matter expert to the Assistant Secretary of Preparedness and Response, and I do it in a variety of capacities. So I don't just do home care and hospice, because I am the only expert for home care and hospice in this area. But I also have worked on crisis standards of care. I've worked on durable medical equipment. I've worked on nursing projects. We have been written into every single document, but just wanted you to know that I have pushed this upstairs informally, much as I did with the ransomware event, and sent an email last week stating, you can write us into every darn document you want, but until you put us at the table, it means nothing. And this is what we have to live with right now. You want to push patients out to us for surge? We're not ready. We don't have the PPE. We have not been at the table. So you need to push this right back up. And there is a committee that's looking at what we call the pillars of preparedness. And we do have a pillar. And the person that is representing Asper Tracy is someone who is a very big advocate for home care. Her mom is a home care nurse. And Kristen Finney has always been a strong advocate for us. So I have continued to give them updates. May not make a darn difference for this particular pandemic, but I'm hoping that somewhere along the line it will make a difference as we continue to plan for further types of events. So I just want to talk about where we are now. And we know that the spread is continuing. People are being told to quarantine for longer periods of time. I do believe in shutting down restriction between states to try and spread. And I have my own theories as we get into PPE about what we should be doing. But this is where we are. We are now in crisis standards of care, which means we have to decide and make some decisions on who's going to be treated, who's not going to be treated, and what kind of treatment is somebody going to get. Crisis standards of care, we started looking at crisis standards of care right after 9/11 with the anthrax scare. And then we began, when I say we, the government, because I am, I consider myself part of what they do. I've been working there long enough. But in my role as a consultant, we have worked on crisis standards of care for a long period of time. We have had a plan in place. Somehow the plan has gone awry. And what we end up now is having 50 states doing 50 different things, wasting much resources that if it had been driven from the top down, which is not the norm for disaster preparedness, by the way, but my personal opinion is if it had been driven from the top down with specific guidance and then some unique nuances for the state, I think we might be in a different place today. So when we look at crisis standards of care, It means now we are operating outside the norm. We need to look at serving the greater good than the individual. And I want you to think about that as a home care and hospice provider. It means that we have to make some difficult decisions. We have long been a culture and a country very rich in resources. And every time I say that, I can't help but go back to the toilet paper shortage. There's a lesson here for us about resources and utilization of resources and how we prioritize. It's not an easy lesson. But if you think back to countries like Russia and some of the other countries, where they count out how many pieces of toilet paper you can have in a day, well, here we are. So as we look at crisis standards of care, it's how we're going to provide care, not the same care that we always give. We're going to have less. So we have to figure out how we're going to do that. And that's where we are as an industry for home care and hospice. We cannot continue to provide care the way we always have. And I'm not talking about one-on-one care. I'm talking about what we do with our patients and how we identify with our patients, who we're going to help, who family can help, and do they really actually need home care? And unfortunately, long term down the road, when we start looking at this, everything at the end of the day is going to have an economic and a financial impact. We're seeing that now. This is going to be a long process. So as we look at crisis standards of care, my advice always is to organizations. In those crisis standards of care have to be self-care for administrators and staff and anyone else working in your organization, because we can't function if we're not taking care of ourselves as well. And I know that sounds simple, but someone reminded me that the other day. I take my role very seriously in what I do. And I had a meltdown. I'm going to be honest with you guys. I had a meltdown. It was Thursday. I was overwhelmed with emails and deadlines and finishing this and crisis management for providers, home care agencies whose employees were now testing positive. And I just couldn't keep up. I just could not keep up. And I made the mistake of listening to the news. So that's the first thing I'm going to tell you. Just pick one news program and listen to it one time a day. This 24-hour coverage is driving us all crazy. But I did. I had a meltdown. I'm going to be honest. I started crying. But not for the virus. I'm not afraid of the virus. I'm afraid of what's coming down the road, people that will lose their houses, that type of thing. But it will be a long process, and we can do this, but we have to look at crisis standards of care. What we're going to do differently to protect our employees, our organization, and our patients. So when we were developing crisis standards of care, and there is a book that comes out of the Institute of Medicine, I was part of that. We had developed it into indicators and triggers. What are the indicators that make you want to stop and look at your process based on what you're hearing, what you're seeing, to start thinking about you might have to use crisis standards of care? For me, that indicator would have been the original December breakout in China, when we had that giant pod of communicable outbreak. I always think you always have to pay attention to what goes on in the world. Our trigger came very fast. So when you moving from regular standards of care to crisis standards of care, as we saw, occurred within 1 week. Now, I'm not asking you to work on this. I'm not asking you to fill this in. I just want you to know we've had a model out there for this. And when we move to crisis standards of care, we're going to be using our PPE differently. We're going to be using our staff differently. We're going to be assessing our patients differently. We're going to be treating them. And we may not even admit some patients, not because they have a COVID-19, but because we know that we just don't have the resources to do it. So when we're looking at resource allocation, and I don't actually have an arrow here that I would have liked to use, but we are actually at 4, 5, and 6 when we look at resource allocation and crisis standards of care. We have to adapt to new protocol and new care standards. We're going to be reusing equipment, and we may be reallocating, taking from one patient to another patient. I do want you to be aware of the fact that during H1N1, many states developed formulas for utilization of ventilators, of who would be allowed to go on a ventilator, and if we needed to remove someone from a ventilator to use it for somebody else. That's always been part of the pandemic plan. I know when you hear it on the news, they really blow it up, but we've always had a plan. Most states have a plan. We don't hear them talking about it because people don't want to talk about limiting resources. But if we have an 82-year-old person who has cancer, who has COPD, as opposed to a 45-year-old with 3 children and no multiple comorbidities, and we have to make a choice, this is where we have to pull emotions out of what we do, which is really hard for us because we have relationships with our patients. We have close relationships. But that really is where we are making determinations. So for what we do, we know staffing, supplies, continuity of care, and still being a functional business are our concerns that are growing every day more and more. So when we look at crisis standards of care, we can no longer do best practice. If you have a patient that doesn't need vital signs, then don't do vital signs. If you have a patient that all you need to be do is observing them draw up their insulin and they're stable, then stay 6 feet back. You don't need to touch them. We have to look at who needs what care and thin it out. I don't want to say thinning the herd because that's a whole nother thing. But we really need to look at what do we really need to be doing for that patient? What is essential care? We don't have to take a blood pressure on every patient. We don't have to take a temperature on every patient. We may not have to escalate lung sounds, but we need to figure that out because we need to limit interaction and decide who needs us the most. What family members can do care? Try to limit the number of healthcare workers in the home. Don't keep changing staff. Now, we may have some non-skilled providers on here who are only doing paraprofessional. That's the same for you. We can't have 500 different aides going into the home. We really have to limit the amount of healthcare workers that go in. The regulations are stay 6 feet away from the patient. In some cases, that's going to be hard depending on the care that we're giving. And so that's why you have to look at each patient's plan of care now. You have to look at your staff as well. And we have to understand, and it was really interesting for me because I had to go back to my old infection control manual that I did in 2007. Because I had a whole chapter on pandemic and cleaning equipment. We have to go back to the basics. What's critical, personal protective, what's non-critical. Blood pressure cuffs are non-critical. They just have to be wiped down. Expect that we're going to have 2 lines of service. We're going to have COVID-19 service patients, and we're going to have non-COVID-19. So we need to look at care. We're not doing best practice. We're really only going to be doing the bare essentials if we have PPE shortage. And we know that we're seeing referrals from hospitals now as they discharge COVID-19 patients that are stable. Since we have a shortage, and Pat and I spoke about this, when you get a referral from the hospital for a patient, especially COVID-19, ask them to give you personal protective equipment. Kind of sad. This is the only way I could take this referral. Our industry is experiencing a shortage. Could you send a patient home with personal protective equipment for our healthcare workers and tell that patient to leave it in another room where they are not? They can do that. Hospitals are going to be top priority. They are going to get PPE long before we do. And the other thing that you can start to consider is in treating COVID-19 patients. If you have any employees who have been diagnosed with COVID-19 and fit into the return to work criteria, you can use them to take care of COVID-19 patients. So we do have some flexibility, but it's a change in the way we think. So you've got to think no more best practice, no more altered standards of care. We are in crisis standards of care. And this is happening all across the country. Home care and hospice are not getting PPE. At this point, you should be asking your staff to do self-monitoring either once or twice a day, taking their temperature, are they feeling ill, and need to report in, depending on how your staffing is, to report in only if they're not feeling well, which we call charting by documentation by exception. You should be calling patients prior to making visits, checking them, and the tool that I gave Megan was a screening tool, that kind of algorithm of what direction you need to give in. And at this point, you should be identifying any of your employees that are at high risk should they be exposed to COVID-19. So we're talking about women that are pregnant. We're talking about anybody who's immunocompromised, perhaps somebody who is older, recognizing that in our industry that we have one of the oldest workforces. And while we don't like to actually impose, and we do have some limitations on what we can ask, you can certainly just ask people if they are, or they feel that they're high risk, that they identify themselves to either your HR people, but something confidential, so that you know that where you can assign those patients, those employees rather, you're going to assign them to non-COVID-19 patients. We are beginning to see in these epicenters, so that right now is in Texas, New York, New Jersey, Connecticut, home care workers being exposed and patients being exposed. We're seeing paraprofessionals being diagnosed with COVID-19. So you really need to have some policies. We're looking at 14 days from the close contact with the exposure or the last day of contact, when you're going to let them return to work, and how you're going to identify the circle of exposure. So an example would be if we had an aide who we find out now is in the hospital because she's been diagnosed with COVID-19. You find out the day she was symptomatic, if at all possible, and look at the circle of care, who received care from her or him. And from the moment that they were symptomatic, you count back 14 days. And then you notify those patients and any other healthcare workers that this person may have come in contact, close contact, within 6 feet. But you would have to notify your patients that they may have been exposed to COVID-19. You don't identify who the personnel is, but that they should be contacting their physician, and you would want to monitor those patients for symptoms as well. And then how far out does it go? Did that employee make a number of visits? Do they only see one person? We've had an example of a coordinator who didn't show for work for a week and then called in and said that he had been diagnosed with COVID-19 and had been in the office a week ago. So from the day of his last exposure in that office, everybody in that office had to go home and self-quarantine. So those are the things that are happening that change the way we practice. You've all heard conservation of supplies. The deal is now, if you have expired N95 respirator masks, you may use them. Please make a policy and please write down all of the manufacturer's information. There's no guarantee of how much protection you'll get, but they are allowing us, because we're in crisis standards of care, there is recommendation. If that's all you have, you can use it. And how do we use PPE in crisis standards of care? So as I said, we're now able to use outdated N95 respirator masks. If you don't have alcohol, remember the good old days when we used soap and water. Of course, if you can find paper towels, that will be a miracle. But alcohol, if you have it, if we're lucky, we still have plenty in some places. But you washing, gowns, eye protection, gloves. Remember, it's recommended that we use airborne, but without this type of protection, then they give us, the A being CDC, gives us some guidance. So when you see, and I've seen this incorporated into home care policies, when you look at CDC and they're talking about the reuse of N95 respirator masks, most of this reuse is based for facilities. So extended use, that you can wear the same N95 respirator mask without taking it off between patient encounters. That does not mean us, because we are going from house to house. And remember, the front of that N95 respirator mask then becomes contaminated if it's a COVID-19 patient. So I've seen this written into many home care documents right out of the CDC. This is not for our environment. Also, I've had a lot of questions about fit testing for PPE. If you happen to be lucky enough to have N95 respirator masks, which most of us in the industry don't even use, so we don't have it, forget about fit testing. If you only have one kind of mask for everybody to use, there's no point in fit testing. The whole point of fit testing is to find a mask from a choice. If we're not going to have that, then the fit testing doesn't actually make any difference. But you can do fit checking, which is you put the mask on and you breathe out and you try to make sure there's no air coming out. You try to get a best seal. But because we don't have many N95 respirator masks, many of the state Department of Health and Office of OEM are saying, if you only have one N95 style, don't even bother with fit testing. It doesn't make any sense. Reuse means taking off the N95 respirator mask and putting it back on after you've had multiple encounters. Again, this is for the facility. We're not going to take a mask from a patient, an N95 respirator mask from one patient, box it up, and go to patient number 2 if it's a COVID-19 patient. There's not much out there for home care, but we do have some pieces that I put together after H1N1. Most of us are going to be working with surgical or procedure masks. It's always been one patient, one mask, but we do have some options, and I'm just going to take a quick drink here. Excuse me. You can leave a mask in the patient's home if you feel that the environment is safe and nobody will touch your mask. So, and as you can see, Mickey here is wearing an N95 respirator mask. So let's pretend that Mickey doesn't have that on. Let's just pretend you have a loop mask. So if you want to take a surgical mask and you put it on and you're going to do some patient care and the inside of the mask is not wet. Remember, if you're a mouth breather, once that inside of the mask becomes wet, you can't use it anymore. But this goes for our aides as well and anybody else. If you want to leave a mask in the home, you have to take the mask off by the loops. You don't touch the front of the mask. You can put it in a brown paper bag, no Ziploc baggies. You're going to fold that mask inside out. So the outer part goes on the inside because that's contaminated, and your clean part remains out. You only handle it by the loops. You can keep it in a brown bag. That brown bag only has one use. You can put it in a larger plastic container that has air, not a baggie. Same thing then, that container only has one use. So, but you can use that mask over. Now, you could do that in your patient's home. I'm not a big advocate at this point in time of taking our masks from one home to another. Now, if you have an N95 respirator mask and you want to put a regular mask over that, You can do it, but I'm still not a big, and I know that some people are using their N95 respirator mask going from home to home. I am not an advocate of that because we don't know enough about this virus. And if we're not removing it properly, if we're putting our hand over the face piece to take it off, we've already contaminated ourselves as well. I'm more concerned about us taking a mask, contaminating ourselves, and bring it home. Now, we have heard about this option. We already talked about this. Cloth masks. Now, you need to know cloth masks, there are two different studies out there. The scientific studies say you're better off not wearing a mask at all. The cloth masks, depending on the material, and right now we're just using everyday material from fabric stores, those masks hold moisture. And we don't know what the barrier is of preventing a virus to come through. Now, we know in some cases they're putting vacuum cleaner HEPA filters in. I do not recommend these for patient care, but it's going to be, we're at a point where it's your choice. If you think wearing a mask is better than nothing, we don't have any scientific evidence that's going to tell us that, but some articles show that we have a bigger risk of getting infection or some type of exposure because the mask just does not work as a barrier. Now, I have seen recently some documentation using material like umbrella material that your outside chairs are made out of. It's got inside is like a cotton, but outside is water repellent. We haven't done any studies, but some infection control practitioners that are certified, we've been talking online, that might be a barrier. But I'm just telling you, the only hospitals are not using this. There is one place only they will allow the use of a cloth mask, and those are in birthing rooms, that the woman and her partner can wear these during birth, and that's the only place. So I'm just urging you to be cautious about this, but this is where your agency has to make a decision on what's going to be best practice for you under these very trying and unique circumstances. So I'm going to finish with this one slide, and then Megan, we can take questions. This is, as we talked about planning for a pandemic, and quite honestly, my company has done so many presentations and tabletops in the 26 all the way up to 2011. And then, of course, we move on to other things in the world. But you need to take care of your staff. You have a responsibility to keep your staff safe. And at the end of the day, this is what we call moral injury, when there is no right choice. We're going to have to select who we're going to take care of. We're going to have to select what staff we're going to be able to use. And at the end, the choice we make is the only choice we have, but it may be not the one that we can live with, but we have to. That's where we are with pandemic. It's not easy, it's difficult, and it's really hard to move your emotions out because, I am a home care person. I was public health first before I moved into another part of home care. But we have relationships with these people. We're in their home all the time. I know how difficult it is, but we have to move and think a little differently. So just understand that for some people, they're going to experience post-traumatic stress. They're going to be stressed. They're going to be upset about their decisions. And we're in this for the long haul. We can do it. It's just not what we've ever done before. But we can do this, and we can do this to the best of our ability. Megan?
Thank you so much, Barbara. All of that was really great. So we have a couple of questions. A reminder, if you do have questions, you can type it into the questions box. I know we've gone a little bit over the half hour that we said, so if we run out of time, I will send out these questions to Barbara so that she can answer them. And if you think of them afterwards, you can email me directly, and I will take care of that. So just a couple of questions. You covered a lot about the PPE and how CDC isn't really putting into consideration home care workers and stuff. Um, one person was specifically wondering if there's anything that exists for how to's, with an example of, putting on PPE in a hallway of a high rise. So we have to carry other equipment items, possibly as bags and scales, etc., that are needed for the visit. And obviously they would be traveling lighter to these homes, but still looking for any thoughts on how you might suggest to do that.
My suggestion, if it's at all possible, and I certainly get making visits in high rises, I would say if there's a single person who has to answer the door, there's nobody else in the house to let you in, then I would suggest, yes, you can go ahead and put on some preliminary PPE. Remember, if they need a gown, you could, the way that we put on our PPE is gown, mask, goggles, gloves. Now, you may not need all of that depending on if we're talking a COVID-19 patient. If you're lucky enough to have that, then yes, right before they open the door. I would also suggest, if the patient can actually be in a different room when you get in, as soon as you do the entry into the house, you could don your personal protective equipment there. I would also suggest we do double barriers. So when you're putting out your equipment, and again, limit your equipment. Don't take out something you don't need to use. If they don't need a blood pressure, don't take out your blood pressure cuff. You're not going to be listening to heart sounds, don't take out your stethoscope. But I would put down a barrier that I'm going to put my equipment on that's clean coming out of my bag. When I am done with that equipment, I would put it on a different barrier, because that's going to be where I'm going to clean. And once I'm cleaning my equipment, I would put it back in my bag. But you could do it in the hallway, but if there's like a little room, and at this point in time, tell all of your patients to keep a waste basket by your exit, by the door. So as you're taking off your PPE, now this is for COVID-19 patients, that you can just take off your PPE. They need to have a garbage can with a plastic bag. And when you take off your PPE, put it in the bag and tie the bag. They can put it in regular trash. So that's not a problem. I hope that answered the question.
Thanks, Barbara. Another one with that is a little bit more on, you know, do you know of any videos out there that maybe people have used with donning and doffing for reusing slash cleaning equipment, for the reuse of it? I mean, obviously it's something that isn't typically done, so I wasn't sure if there's anything out there that they can give to their employees for examples.
The only guide, I don't know of any videos, to be perfectly honest with you. The guidance on how to don and doff is on CDC, and the guidelines that they recommend for reuse are out there, but just remember, it's not geared to home care. So if you can adapt it, which essentially is what I do when I look, because they don't know our practice. And that is actually the most I've seen. We will be
Okay.
developing things, but right now we are in crisis mode also. And by the time we publish and produce, we're going to be past probably where in the next 2 to 3 weeks, we're expected to hit the apex. I have a question, and so maybe people can put into the chat room. Are you being sent COVID-19 patients by the hospitals? Because we're seeing
I
some
do.
hospitals set up recovery centers without using home care.
If anyone is on here who has been sent, I do know that some of our agencies have been sent some patients. I know one of our hospitals is becoming in Dorchester, I believe it is the main COVID-19 hospital in the area. So any home care agencies in the area I know are starting to see patients. Yeah, so we're definitely getting some agencies telling me that they are seeing some patients. Actually, I had a question relating to that a little bit. They said for COVID-19 positive patients, well, that's not the right one, but I will get to that one. But I just know there was, sorry guys.
That's okay. While you're looking at your questions, the other thing is every single state has a healthcare coalition. And you may not get any PPE from them, but I want you to find who your healthcare coalition is, and I want you to call them, and I want you to request PPE. And the reason that I want you to do that is because they are funded by federal money, and their job is to coordinate care and utilize and share resources. And I'm going to ask you to please document this. Whatever response you get, send me as much information as you can, because I know it's not going to help us now, but I fully intend to take this with me when I'm sitting at the table. They're getting federal dollars, and some coalitions have been very kind and include healthcare and home care as equal partners. We have some states that have done very well. We have Maryland, we have Rhode Island that are actually giving PPE. Not everybody's getting a full request, not even the hospitals. I don't want you to think that. But the hospitals will get first priority. But I want you to make those email and written requests for PPE, and I want you to send to me at my RBC email all of the things that you need, how much you think you need, because I'm going to be compiling all that data, and I've asked other states to do it as well. Again, probably is not going to help us with this very much, but in the next week, the more information I have, I continue to report, and I continue to say this is the problem, and I have a lot of great informal support. And so I will just continue to push it upstairs, and I'm hoping that we'll be able to make a dent. Megan?
Thanks. Yep. Great. So there was a question. It wasn't necessarily regarding to a patient being in the home, but it was more of how long once the patient is home and asymptomatic, do clinicians need to continue wearing PPE, knowing it's not realistic that the patient is tested again for 2 times to show 2 negatives?
Okay, so let me make sure I understand it. The patient has never been tested negative, hasn't had the 2 tests 24 hours apart, correct? But they sent home.
It seems
right?
That way, yes.
Okay, so a person that has been 7 days at least, 14 days probably better from the time their first symptoms appeared, and have gone at least 3 days. I would go with 14 days. At least 3 days without a fever, without taking anything to lower their fever, and diminished respiratory issues, cough, shortness of breath. So 14 days, and then I would want to see that they've been afebrile for at least 72 hours without taking Tylenol, and they have no respiratory issues after that point, so far as we know. So remember, we don't know truthfully a whole lot about it, but that would be my guideline. And then after that, it's going to be how comfortable are your employees going in, and when do they feel comfortable not wearing a mask? They're still saying, they being CDC, that we don't have to wear a mask if it's a non-COVID-19. I agreed with that in the beginning. I'm not so sure that I agree with that anymore. I'm not so sure that, and this is my personal opinion, I don't have any scientific evidence. I'm not so sure that I agree that people should be in the grocery store without a mask if they're if they're fine. I just don't know, because I haven't seen anything that's telling me that any numbers are of significant improvement. So you have to, as an organization, you have to look at who your patients are, prioritize them. May be hard. The other piece is, and I don't know if I said this earlier, but we did get some relief from HIPAA. There will be no privacy penalties for using telehealth. So now you can use Skype. Now you can use FaceTime to monitor your patients. So you can, I can't address reimbursement. I don't ever trust anything that they say about reimbursement, because I saw what happened with Hurricane Sandy and Katrina. But in the meantime, if you can limit visit time and you can make a couple of visits using Skype or whatever they are, I don't actually use a whole lot of social media in that aspect, but if you can do it, they have waived the penalties for HIPAA privacy violation for this particular situation. So look at using those models and you have to reformulate what you do. Every agency on here is different, so it's hard for me to give specific guidance. We do crisis management. If you want to talk to us, you want us to help you with that, that's a whole different thing. But you have to look at your employees. You have to look at who's standing at the end of the day. A lot of people are home taking care of their kids. Our workers have kids that they need to take care of. We are deemed essential. Home care is deemed essential, guys, at no matter what level of home care you are, whether you're skilled or non-skilled. And you have to make a decision. I have some agencies that their employees don't want to take care of COVID-19 patients, and you can't force them to. So this is where each agency has to look within their structure, look within your philosophy and your mission, then look at your real capabilities, where you are with PPE, and what can you really do. And now take those levels 1, 2, and 3 and re-triage them again. And do that constantly and make a decision. Are you comfortable with your staff going out without any protection on their face? That's your decision to make. We have guidelines, but ultimately it is your decision. Any other questions, Megan?
We had just someone asking what coalition do they contact to request federally funded PPE?
The actual name of it is Healthcare Coalition, and every state has them. I don't know how many you have in Massachusetts. I will send a list, Megan, if that's okay to you. I will identify who your coalitions are.
That would be great.
And that's who you call, and you call you have counties in Massachusetts, right? I hate to sound so dumb, but
yes. We do, yes.
I was just dealing with parishes. Contact your county office of emergency management and make a request for PPE. And you need to document these. So I would do my healthcare coalition. I would do my county office of emergency management and see what happens. All of those requests get pushed up, and then the state makes the decision on who is going to get part of the PPE. I would suggest, and I'm sure, Pat, maybe you've already done it, writing a letter to the governor addressing home care, and I can help you with that as well, using the words, and requesting that they must be considered for PPE as part and parcel of the dispensing of it. We've taken out of the strategic stockpile, but what we took out of the strategic stockpile was expired PPE. So if you have expired PPE and you want to use it, go ahead. It's still better than nothing at the end of the day. But you need to document that, and if you're going to use expired PPE, make sure your agency knows your employees know that it's expired, because down the road we have to be concerned about liability. This is tough. This is a tough one for us, because while we've prepared for it, home care has moved on to so many different things. We've got a new reimbursement system. Every state is operating differently. We have federal guidelines coming down for COVID-19. We have Medicaid guidelines coming down because that's from the state because they contribute 50%. We've got FDA. We've got OSHA. We don't have anything coming out from one place. And what I try to do is kind of look at all of that and what does it mean for us in home care that makes sense, and that's what I've always done. So any other questions?
I know we've gotten just a couple, and I know, Barbara, if we need to call out, just let me know.
Let's go for 2 more questions and then we'll be done. It'll be 2:00.
Okay, great. Sorry. Where'd it go? Sorry, guys. All right, so they're wondering, so Medicare patients, they have no guidance to do telehealth visits like they do for mass health patients. Do you have any thoughts on that?
I thought you could do telehealth, but you can't get billed. You can't bill for it. I believe you can do it. You just can't bill for it. And we haven't seen any telehealth codes come out for home care, but they have come out for physicians.
I'm just trying to sort through. One quick question is, will they be able to access the slides after this?
Sure. I will PDF it and send it to you, Megan.
Okay, great. So everyone, I will send this out, the slides as well as the recording and the resources in an email after this is over. And then let me just see. So it's kind of a two-in-one. So one person, I know you talked a little bit about storing, the face masks and stuff like that in a home. But they were wondering if N95 could be safely reused because they can't fold like a surgical mask.
We're saying that, so, all right, I need clarification. When you say reuse for the same patient in the same home, or are you talking about moving from patient to patient?
This says reused in one home.
Yes.
Can it be safely reused in one home?
We don't know how safe it can be, but you would be doing the same thing when you take it off. But the answer to that is yes, simple yes. You can reuse it. Again, when you're taking it off, you can't touch the front. When you're putting it and storing it down, dirty, contaminated side down. And when you're putting it up, putting it back on, then make sure that you're not touching any part of that's contaminated. Till it no longer works or it's wet or moist. Always remember the outside is contaminated. Again, hand washing, glove use, hand washing, hand washing, hand washing. If any of you are using face shields, which we should see a significant increase in the supply of face shields from manufacturers over the next couple of weeks. Face shields can be clean, but you can't clean the styrofoam part that rests on your head, but the actual mask can be cleaned.
Okay, great. And then so just one other question was regarding, I know you were saying, PPE, like especially the face mask, shouldn't be, you'd prefer them not being used, multiple times, going from one home to another. But do you have any suggestions for those who do have to by safely storing it in their car?
Then you need multiple containers, because each time you take that mask out, that container can't be used again, which then means how are you going to clean them? How are you going to clean those containers? And again, you can only reuse a mask until the inside becomes wet. But you would do the same thing. You would bring a container. You're going to take the mask off, dirty side down, contaminated side down. I'm really hesitant about bringing that mask from one house to another because we don't know what's on the surface of that mask, and you're going to go from home to home. But I'd rather see you not use an N95 and use a surgical mask that's clean.
Mm-hmm.
We don't know enough about how long this virus lives on surface. Now, again, if you're less than 6 feet away, they're saying you don't need to use anything. We don't need to have a mask if we're less than 6 feet away. So that's why you have to make some hard choices on who you're going to use N95 respirator masks, if you have any, and that you're going to leave them with the patient. It's going to be patient dedicated equipment, if you can. If you can have disposable other types of equipment, fine. But I'm really hesitant because all the guidance about reusing masks are for inpatient facilities. Now, if we were treating patients that were being cohorted, then we could reuse that N95 respirator mask around all patients with the same diagnosis. But that's not what we're doing. So you need to be cognizant that you're taking this mask, and if it's going from a COVID-19 patient, you're putting it in a box or a bag, going to the next patient, and you're taking it out, and you're going to use it again. I just don't think, I know we talked about not using best practice, but I think, that's a questionable practice even under crisis standards of care until I see some research. But remember, that front of that mask is contaminated. And you're going to go, how many visits do you make in a day? 4 or 5? And you're going to take that from home to home. And all you have to do is forget for one moment in time, touch it, touch yourself, rub your nose later on if you didn't wash your hands. So I would just be extremely cautious here about that. I can't tell you not to because you have to make your own decision. This is just guidance, but I would not want somebody coming in my house that used a mask with somebody else that had COVID-19. So I ask you to think about that. I know you have a shortage, but we have to think about the safety of ourselves, our families, and our patients. You don't want to be bringing something home either. It's going to be in your car, and I know it's in a container, but those are one-time container uses only. Where do those containers go at the end of the day? You're bringing them home to clean? Are they going back to the office? Those, you have to kind of think out past that. There's more here than just patient care. Okay, Megan, I got 2 o'clock, babe.
All right. Well, thank you so much for taking this time. Thank you for those who were able to call in. So again, if we didn't get to your question, I'm going to send everything that was sent out that was asked today to Barbara. Again, you can email me directly, and I can compile any additional questions that weren't asked on the call and send it over to Barbara. We know it's crazy time, so we'll do our best to really get this done. For those of you who aren't aware, we are doing another member call, and Kim Skehan from Simeon, as well as Colleen Bayard, our Director of Clinical Services. Everyone knows Colleen. They're going to be facilitating the call tomorrow with questions and answers. So that is at 12:30, and if you need the call-in information, just let me know and I can send it out. So thank you all. Thank you, Barbara, and good luck, everyone.
Bye-bye. Take care, everybody. Be safe.